Gentlemen, my talk is risk stratification of asymptomatic diabetes, and it's a topic that I've been interested in for the last 17 years. And this trial that I'm going to present, the PROCEED trial, is really an attempt to develop a model where we use patients' risk stratification, cardiac risk, atherosclerosis measurements, and biomarkers, and novel biomarkers. So the global burden of diabetes is huge. According to WHO, by 2035, there'll be 600 million diabetics. And really, the greatest number of people with diabetes are between 40 and 59 years of age, and they are distributed in low and middle income countries. And India is a country where diabetes is a major problem. The cost of managing coronary disease and diabetes together is expected to be over $20 trillion by the year 2030. This data is available in the Diabetes Atlas. Now, as you know from coronary artery calcium imaging, this data was very interesting. This is observational and not a controlled trial. 9,000 patients were studied by Dr. Shaw and colleagues, and you can see that as the coronary calcium score increases, so does all-cause mortality. This is 4 to 5 year. If you take the 900 diabetics similarly followed up, you can see that diabetics have a much earlier, so with a score of 400 and over 1,000, the mortality is much higher. So we are missing something. And in 2002, we did a trial called the Wellington Diabetes Trial, and this was the first time where a prospective trial was performed in 510 asymptomatic patients without any evidence of heart disease. And electron beam CT, calcium scan, biomarkers, risk factors were performed, and if there was a coronary calcium score over 100, then a myocardial perfusion scan was performed and follow-up. This resulted in changing the guidelines of the ACC, American Heart Association, European Society of Cardiology, and the British Health Service. And what we saw that about 46% of these patients who had evidence of atherosclerosis and mild disease in 20%, 15% had moderate disease, and 11% had severe disease. So we carried out myocardial perfusion in these patients, and we were surprised to see almost a linear relationship with the large, moderate perfusion defects. So ischemia or silent ischemia was present in these patients with asymptomatic coronary calcification. So this was the first trial to show the role of the combined tests. And here's an example of a 57-year-old man who has a score of 478. He has risk factors, but no symptoms. In fact, he's had a myocardial infarction, but he has a normal electrocardiogram. And then on the stress, he has extensive ischemia, and then he underwent multiple PCI. So if you look at the risk factors, even within 18 months, death, MI, acute coronary syndrome, stroke, and late revascularization occurred if the score was 400 or 1,000. There was a clear-cut separation between the lower scores. And similarly, with a 5% global ischemia and a 10% global ischemia, that was also shown to be very prognostically significant. Now, the normal thing that you measure is high sensitivity CRP. And we found absolutely no relationship with high sensitivity CRP and calcium, and neither with interleukin 6, because these were stable patients and not patients with acute coronary syndromes. So, but we used another new technique called osteoprotegrin. It's a biomarker, and we found that this was related to increasing coronary calcium score. It is a marker of plaque modulation and disease progression. The next generation was CT coronary angiography. This is a dual source CT. The technology has improved significantly now. The quality of the images. This is a young man, diabetic, who has a cricket ball injury and fractured ribs, comes in with a funny wrist pain. The GP was very smart and sent him to me on a Friday evening, and he has very severe lesion in the proximal right coronary artery, and it's a mixed disease, and this is called spotty calcification. It's an unstable disease. And the coronary angiogram shows identical change, and he had a PCI and was stabilized. So what we can do with a plaque, with CTA, is look at plaque morphology. We can look at the plaque volume, we can look at the plaque size, we can look at plaque morphology. And this technology is just at the beginning and is increasing rapidly with expertise and better computer technology. So the next stage was the PROCEED trial. We wanted to create a model of patients with asymptomatic diabetes, the same sort of patients, and we wanted to look at the role of CT and to compare this with endothelial function and vascular inflammation. So cardiac CT, patients with the usual traditional risk factors and novel biomarkers. And I will talk a little bit. I can't talk about the whole data, but I'll summarize very quickly. So the age there were 359 patients, 259 patients with an average age of 61. Their diabetes was longer than the previous studies, 13 years. And you could see their cholesterol, LDL, HDL, and diabetes control was excellent in this group. These were patients taken from hospital clinics. So they were well-treated, asymptomatic diabetic patients. Now look what we found. Only 23% had zero coronary calcium. There was so basically over 70% had evidence of atherosclerosis, and in fact, moderate to severe was quite significant, 29%, 14, and 7%. Now these patients with a score of over 1,000, they have so much calcification that doing CT angiography is not possible, or not, it's possible, but not good enough data, so we excluded them because they were fast-tracked into coronary angiography. So we used a 50% as a cutoff of stenosis for a major vessel. We used a modified Gensini score, and we'll forget the carotid, and we looked at quantitative as well as visual analysis. So when you compare between a normal CTA and that of an abnormal CTA, the factors which separate them is age, male sex, duration of diabetes, and hypertension. Then we look at the difference between the ones with the significant, non-significant disease and those with greater than 50 or 70% stenosis. Again, the same factors, but there is something interesting that HbA1, hypertension stays there, microvascular disease, systolic blood pressure, and HDL. So finally, if you do a log rank test, then the ones which separate is duration of diabetes, systolic blood pressure, HDL, and of course, coronary calcification, which is understandable. So we had 92 biomarkers. These are very, very new techniques, and we're done in Sweden by my colleague, Professor Jan Nielsen, who's the director of the Swedish Heart Foundation. And I just briefly show you that coronary atherosclerosis is a very complex procedure. And what happens is that we are looking at lipids and inflammation, we're looking at cell death and degradation, and matrix repair and plaque stability. So when we compare that, to our surprise, again, the cytokines, interleukin-6, CRP, inflammatory markers were all negative, and they did not compare with plaque modulation. Neither did the chemokines. But when you look at metalloproteases, this is the tissue remodeling factors, they were strongly positive, and they correlated with coronary plaque. And then we looked at apoptosis markers, here TNF-alpha, TRAIL, osteoprotegrin, again becomes very positive like our previous trial, associated with plaque disease. These are asymptomatic patients, remember, and then growth factor was strongly related, and renin, NTN, proBNP, myoglobin, and these factors were also associated with plaque disease and spondylin. So in summary, no association or minor association with cytokines, chemokines, and smooth muscle cells. So I would say that CRP is not very useful in stable patients. And here, when you look at extracellular matrix, markers of apoptosis, endothelial cell growth factors, markers of cardiac stress, homeostasis, and spondylin, there was a significant associated with coronary atherosclerosis. So in conclusion, Mr. Chairman, ladies and gentlemen, silent coronary atherosclerosis and significant obstructive disease is common even in treated diabetic patients, well-treated diabetic patients. Coronary calcium scanning predicts the underlying coronary disease and can be used as a screening test. But a model based on risk factors, novel biomarkers, CT plaque imaging may produce a robust marker where you can select the high-risk patient for further imaging or treatment. Thank you very much for your attention.
We can have one comment.
Yes, sir.
Since it's known now that diabetics with 0 calcium scores or totally normal CTAs have the same outcome as non-diabetics, do we really assume that diabetes is a CAD equivalent?
Excellent question, and I think it is. But the problem is, if you're talking about, let's talk about India. We're talking about 100 million patients with diabetes. How are you going to screen? We can't do CT on everyone. So the idea was to create a model where you do look at the risk factors and biomarkers, and then sub-select the ones for imaging. So that was the idea. So it is the individual patients, if you look at, we don't know which plaque is going to rupture, creating an acute coronary syndrome or myocardial infarction. So the whole idea of this huge burden of diabetes, which is going to place an economic burden on countries like India, China, the Middle East, Africa. Here, I think it is important to try and hone on a group and to create an imaging, biomarkers, as well as risk factors, a model with which we can select those at high risk of developing severe atherosclerosis or those with unstable disease.
What was your correlation with carotid, this intimal medial thickness and coronary plaque?
Very good, but the problem is not as good as predicting events. It's not as good as predicting events.
Thank you. Thank you. You can join here. You can also come.
Thank you, Dr. Avijit Lahiri, for a timely talk. And may we request Dr. Yashpal Sharma to present Dr. Avijit Lahiri with the memento and certificate.